like to have your recording played, or would you like to present live? Either ways.
Let's just play the recording. I'm at home right now since it's Saturday morning, and I think it's more reliable to do the recording in case the connection is in and out.
Fine. All right. So, Professor, you can start.
Good evening, friends, and a very, very warm welcome to yet another edition of Heart Failure Bedside Clinics. We have held a number of these clinics, and all of us have learned a lot in various aspects of heart failure from experts in India and our overseas faculty. Today, we have Dr. Michelle Kettleson with us. She's from Seda Sinai, and we keenly look forward to hearing from her. So over to you, Hari, for proceeding.
Thank you, Dr. Chopra. Welcome to another edition of Heart Failure Association of India Masterclass, which is done with the support of Heart Failure Society of America. So we have their representatives giving lectures in our evening program. And we have a case presentation discussed by the leading academicians across India. Today, the presentation is from AIMS Jodhpur, and the discussions will be from Jipar Pondicherry. So the first part will be by a talk by Dr. Michelle Kettleson on the advances in amyloidosis. So over to Dr. Kettleson.
Hello, thank you for the opportunity to present on approach to cardiac amyloidosis. I have no disclosures. So as a quick overview, cardiac amyloidosis is a condition where there is a protein that the body produces naturally that results in infiltration into the myocardium and a restrictive cardiomyopathy. The two most common sources of the protein are immunoglobulin light chains, termed AL cardiac amyloidosis, which is a form of a plasma cell dyscrasia along the spectrum from MGUS to multiple myeloma, or the transthyretin or TTR protein, termed ATTR cardiomyopathy, which in turn has one of two sources, either a mutation in the gene or variant ATTRV cardiomyopathy, or the wild type gene. The protein does not just infiltrate the heart, it goes other places as well, which can offer clinical clues to diagnosis. There can be a neuropathy, nephropathy, typically unique to AL, gastrointestinal involvement, or orthopedic issues. One of the most important clues to diagnosis will be the presence of increased left ventricular wall thickness. And when reviewing an echocardiogram, it's important to remember that a thick heart is not always left ventricular hypertrophy, that is, too much muscle. By terming it LVH, you are unconsciously eliminating half of the differential of increased LV wall thickness. So if there could be too much muscle, explained by loading conditions or unexplained, or it could be infiltration into the muscle. And by far the most common cause of increased left ventricular wall thickness caused by infiltration into the muscle will be amyloid cardiomyopathy. Another important pearl is to think about those patients who have mildly reduced or preserved ejection fraction, most typical for ATTR-CM, and recognizing that if you have a patient with dyspnea, edema, and a preserved ejection fraction, you first ask yourself, is it the heart's fault? Is there a non-cardiac mimic where the symptoms are driven mainly by kidney disease, liver disease, or chronic venous insufficiency? And if it is the heart's fault, then make sure to assess for causes like an infiltrative cardiomyopathy prior to assigning the patient a diagnosis of garden variety HFpEF. It is essential to look for these HFpEF mimics so that the patient is not denied disease-modifying therapy. So how do you do this? How do you have a high index of suspicion for a potential infiltrative cardiomyopathy like amyloidosis when a patient presents with dyspnea, edema, preserved ejection fraction, increased LV wall thickness? Well, remember that the heart failure symptoms are but the tip of the iceberg, and it's essential to be aware of what lies beneath. There can be other non-specific symptoms like fatigue. There can be other cardiac findings like atrial fibrillation, AV block, and pacemaker. Be aware that in patients with severe symptomatic aortic stenosis, older patients, about 15% have concomitant cardiac amyloidosis when tested. And for those patients admitted with decompensated HFpEF when tested, about 15% have underlying cardiac amyloidosis. Think about that increased wall thickness and a discordant, not necessarily diagnostically low, but discordant QRS voltage. Neurologic findings include sensory neuropathy, autonomic dysfunction, typically with intolerance to vasodilators with orthostasis, and these orthopedic manifestations like carpal tunnel syndrome and spinal stenosis can precede cardiac manifestations by 5 to 10 years. So the first challenge is to have this high index of suspicion, and the second challenge is to order the right tests and interpret them in the right manner. So here are the 3 ±1 tests you may need to come up with one of the 3 possible diagnoses. You take your clues from the history, ECG imaging, and you do a monoclonal protein screen, which is the essential first step to rule out AL cardiomyopathy. If the monoclonal protein screen is abnormal, you must do a biopsy to confirm the presence or absence of AL cardiomyopathy. If the monoclonal proteins are negative, then radionucleotide scintigraphy is appropriate to perform non-invasive diagnosis of ATTR-CM with subsequent genetic testing, which will identify variants, which will be useful for cascade screening of first-degree relatives. Now, there are some subtleties to this algorithm. Let's talk about them. So when I was in medical school, I remember memorizing SPEP, UPEP, amyloidosis. Not true. SPEP, UPEP are not as sensitive as immunofixation electrophoresis for identifying monoclonal proteins. Don't stop with SPEP, UPEP. Order the immunofixation electrophoresis. Second thing I remember memorizing in medical school, that fat pads are useful for the biopsy for amyloidosis. Not true. Fat pad and bone marrow, these surrogate sites lack adequate sensitivity. Their advantage is they're less invasive. However, if negative, you must biopsy the organ of involvement, heart or kidney, as the gold standard to exclude AL cardiac amyloidosis. Finally, radionucleotide scintigraphy has been a huge advance in our ability to non-invasively diagnose ATTR cardiomyopathy. However, it is only diagnostic if the light chains are negative. That is, there can be false positive scans in patients with AL cardiac amyloidosis. So you must never interpret your radionucleotide scintigraphy scan outside the context of a negative monoclonal protein screen, or you will deprive your patients of the correct diagnosis of AL and potentially life-saving therapies. So the third hurdle, first, high index of suspicion. Second, order the right tests, interpret them in the right sequence. Third is therapies. So the potential therapies for transthyretin cardiac amyloidosis follow a very pleasing pathophysiological algorithm. So the TTR protein is the problem. You can affect production, stopping the synthesis, which can be done currently with RNA silencing and potentially in the future with gene editing. Liver transplantation is of only historical interest at this point because there are so many more effective, less risky ways to silence TTR production. The second is to take that TTR tetramer and keep it in its happy, stable tetrameric form so it does not dissociate to deposit in tissues. That's the TTR stabilizers. And finally, not quite ready for prime time are the TTR depleters that would remove TTR deposits from tissues and reverse disease. So let's talk about these stabilizers first. Tafamidis, a treatment that works. The revolutionary ATTR ACT trial came out in 2018, published 2019. Tafamidis reduced mortality at 30 months from 43 to 30%, reduced heart failure hospitalizations. In the United States, it was approved less than a year after the study was published based on the strength of these findings. Very important, though, when you give patients this medication, you tell them, number one, it's not there to make you feel better. It does not reverse the disease. It's there to prevent you feeling worse. And therefore, number two, early diagnosis is so critical because you want to try to freeze or halt patients as early as possible in their disease course. We now have a second TTR stabilizer on the market here in the United States, acoramidis. In the ATTRibute-CM trial, acoramidis led to a reduction in the hierarchical endpoint of death, cardiovascular hospitalization, NT-proBNP, and 6-minute walk distance. They used something called a win ratio, what I think is harder for cardiologists to understand as we are more comfortable with things like hazard ratios from primary composite endpoints. And fortunately, there was a secondary analysis of ATTRibute-CM using the primary composite endpoint of all-cause mortality, cardiovascular hospitalization, and in fact confirmed comparable benefit of acoramidis versus placebo, also available, approved in the US in November 2024. So that takes us through the stabilizers. What about the silencers? Well, we know historically they've been FDA approved for use in neuropathy, variant form with neuropathy based on these two landmark trials, Apollo and NEURO-TTR. They reduce progression of neuropathy. There was some hint of benefit in cardiomyopathy from post-hoc analyses and surrogate endpoints. There were two initial trials specifically in cardiomyopathy. Endeavor was stopped early due to deaths in the treatment arm. Apollo B, the primary endpoint, was 6-minute walk distance, which isn't a very exciting endpoint, which is why patisiran was not approved for use. But now we have a new kid on the block, which is vutrisiran. In the Helios B trial, vutrisiran versus placebo met its primary endpoint, death, cardiovascular hospitalization, heart failure, urgent visits, with preservation of 6-minute walk and quality of life, just approved in the United States a few months ago. So now there are 3 medications, 2 stabilizers, tafamidis, acoramidis, 1 silencer, vutrisiran, all effective against placebo for improvement in survival, reduction in cardiovascular hospitalizations. And stay tuned because another silencer, the results of CardioTransform, should be available next year. So now that we have 3 medications on the market, the million-dollar question, and in the United States, literally a million-dollar question based on the cost of these drugs, is which medication can you choose? So can we go back to those randomized controlled trials to answer this question? No, in fact, we can't, because the trials enroll distinctly unique populations, so the endpoints cannot be compared. Just look at the baseline characteristics of ATTRACT, ATTRibute, and Helios B, which enrolled patients successively over a 10-year span. Patients in ATTR ACT were sicker based on their NYHA class, their NT-proBNP, their 6-minute walk distance, their KCCQ scores as a marker of quality of life. So really quite extraordinary that there is an era effect, that patients were successively healthier at enrollment because of better earlier diagnosis and heart failure management. That's also shown in this survival analysis of placebo and treatment arms of all the trials. And you can see that the placebo arm of ATTRibute-CM in green did better than the treatment arm of ATTR-ACT in red, and the placebo arm of HELIOS-B in light blue did better than the treatment arm of ATTRibute-CM in dark green. And in fact, the treatment arm of HELIOS-B had survival approaching age-expected mortality as if the patient did not have amyloidosis. What is the lesson here? We're getting better at diagnosis, we're getting better at heart failure management, and now we've transformed this condition from something patients die from to potentially something they die with. But all this good news means that comparing trials is comparing apples and oranges. We can't do it. So how do we put it together? What is my take on this therapeutic landscape? If you have a patient with confirmed ATTR amyloidosis, the first question you have to ask yourself is there end-stage disease? Because if there is end-stage disease, they are beyond the bounds of therapy, because these do not reverse disease. They just preserve patients where they are. So class 4 symptoms, bad kidney disease, low blood pressure, bedbound, they're not going to derive benefit. Are there any non-medical specific characteristics that would warrant one therapy versus the other? What's a non-medical characteristic? Like insurance. Does a payer prefer one medicine versus the other? Choose that medication. All work against placebo. We can't judge relative superiority. Give whatever's cheapest. If the insurance doesn't have opinion, then what about neuropathy? We know these silencers, but not the stabilizers, have benefit in neuropathy. So we would choose vutrisiran, the silencer. And then maybe the patient has a preference. They don't want to take a med every day. They'd rather take a med every 3 months subcutaneously. Then you might pick vutrisiran versus one of the stabilizers. What about guideline-directed medical therapy? This is the beautiful figure from the 2022 heart failure guidelines, which tell us about quadruple therapy for HFrEF and the benefit in HFpEF, but think differently in restrictive physiology. Remember that patients with cardiac amyloidosis have a fixed stroke volume. They need their heart rate to maintain cardiac output, so beta blockers are poorly tolerated. They cannot increase stroke volume in response to afterload reduction, so vasodilators like ACE-ARNI-ARB are often poorly tolerated. So we put it all together. Caution with vasodilators and beta blockers. MRA and SGLT2 may assist in relief of congestion. Remember the high thromboembolic risk in the presence of AFib and anticoagulate. If they have neuropathy, vutrisiran. If they have no neuropathy, then think about cost, access, and patient preference to choose your medication with insufficient evidence to recommend combination therapy. Finally, glimpses into the future. Gene editing is an exciting potential advance which can silence production. We now know from proof of concept trials that it works to knock down TTR levels. Whether it offers added benefit clinically to the silencers already available is not clear at the moment. I'm far more excited about antibody depletion, monoclonal antibodies that bind the fibrils and remove them from tissues. There is biomarker and image-based evidence that this can reverse disease. That is what I'm very excited about. So when do you refer to an amyloid specialist? I think if you have an uncertain diagnosis, equivocal scans or abnormal monoprotein screens. At least in the United States, prescription of these medications can be complicated. A tertiary center can help. If the patient may be a candidate for advanced therapies like transplantation or for access to clinical trials. So in summary, what do we know? We know that ATTR-CM is more common than you think, have a high index of suspicion in the face of clinical clues. We know that non-invasive diagnosis is possible, but your radionuclide scintigraphy is only diagnostic in the presence of a negative screen for monoclonal proteins, and we have 3 effective evidence-based FDA-approved therapies. We need to know what standard of care should be. Is it a stabilizer or a silencer? We know currently it is not both. We don't know how to assess response to therapy and what to do about non-responders. And finally, when we get too good at diagnosis, Is there a role for prophylaxis of asymptomatic individuals? Thank you so much for your attention. It's an honor to be invited.
Thank you, Dr. Kittilson, for that wonderful, very clear presentation on the topic. I think we know that you are the expert in this field, and we are hearing from the horse's mouth. So, one comment or one question. So, you said the immunofluorescence, electrophoresis, once the techniques have been standardized. So, how many percentage of patients you will send for biopsy?
You know, AL amyloidosis is far rarer than ATTR, but of course, if you have an abnormal monoclonal protein screen, it could be MGUS, monoclonal gammopathy of uncertain significance, and you can't tell the difference without a biopsy. And in older people, MGUS becomes more common. So if you look at published series, about 5% of the people for whom you do an amyloid evaluation will have an abnormal monoclonal protein screen warranting a biopsy. And I typically go straight to endomyocardial biopsy as the gold standard. A few caveats there. Number one, the monoclonal protein screen is comprised of the serum IFE, urine IFE, and the serum free light chain ratio. But the serum free light chain ratio can be different if you have kidney dysfunction, which interferes with the clearance of kappa and lambda. So it could be falsely elevated. So if I have any concern, an elevated kappa lambda ratio, a normal serum urine IFE, abnormal kidney function, I will often go to my favorite hematologist and say, listen, I really think this is normal. I don't want to biopsy the patient. Do you agree? But if there's an abnormal ratio and any monoclonal band on serum or urine IFE, the patient has bought themselves a biopsy because you cannot miss AL amyloidosis, which is a median untreated survival of less than a year. Those patients would need plasma cell-directed therapies. Turns out to be about 5% of patients total.
Another point you said is you will in ATTR you will always check AL, and AL negative patients only you will consider for the therapy. So, so will you screen for the light chains in all ATTR even if they are very clinically evident?
You have to. The reason is this: the technetium pyrophosphate scan or radionucleotide scan, nuclear scintigraphy, offers the ability for non-invasive diagnosis of ATTR cardiac amyloidosis. However, 10 to 20% of patients with AL will have a false positive scan. AL can give you a false positive technetium scan. So if you just did the technetium scan and you assumed they had ATTR, and you didn't check for AL, you don't know. You cannot interpret the scintigraphy outside the context of the monoclonal protein screen. So even though AL is rarer, and even though your patient likely has ATTR, you must do that requisite first step because it's a diagnosis that should never be missed.
And any other comments from Sudhir sir, Tarayan sir?
Dr. Kittleson, you mentioned that in your setup, ATTR is much more common than AL. We somehow or the other, despite looking for it very aggressively, after all the education that tafamidis people give us, find it hard to find out patients with ATTR. Most of the patients turn out to have AL amyloidosis. I am also talking about patients who turn up in echo labs with classical features of cherry and top and all the other echo features. Yet when we start screening them, a majority of them turn out to have AL amyloidosis. I mean,
So
I would
meaning,
say
I'm so sorry to interrupt, but meaning not just an abnormal monoclonal protein screen, but cardiac biopsy evidence of AL amyloid involvement.
But if there is AL amyloid already established, we see a lot of patients with renal disorders and hematological disorders like plasma cell dyscrasias and all that. They are the ones, if you have seen the features of amyloid on echo and you do their immunofluorescence and other tests, and you find that there's a strong evidence of AL amyloid, would you still go for ATTR diagnosis?
Okay, so we have to distinguish here between an abnormal monoclonal protein screen and a diagnosis of AL amyloidosis, right? Because an abnormal monoclonal protein screen that has a monoclonal band on serum or urine IFE or an abnormal ratio can mean one of three things: MGUS, AL amyloidosis, or multiple myeloma. And the way you really tell the difference is the tissue. Is there amyloid on a biopsy specimen? So my sense is many older people have the abnormal monoclonal protein screen. And if you have other cardiac suspicion for amyloid cardiomyopathy, you biopsy them, you will find one of two things. You will find either AL in the myocardium, or you will find ATTR in the myocardium. And in some situations, you will find both. That is true. But once the monoclonal protein screen is abnormal, whatever amyloid diagnosis you make must be done on biopsy. And it's true, older individuals can have a combination of the two. They might have AL amyloidosis and concomitant ATTR. What do I do in that situation? Now, which is going to kill them first? AL, clearly. AL amyloidosis is a life-threatening, plasma cell dyscrasia. So what I typically do in that situation is have them initiate the plasma cell-directed therapies with the hematologist, and then confirm how are they responding. Because you have to remember, the ATTR is more of a slow, indolent process. And if they're in that awful subset of patients who have AL cardiac amyloidosis, biopsy proven on a heart biopsy, and they're not responding to plasma cell therapies, and they're older, what am I fixing or treating by also addressing the ATTR? So that's how I think of that situation. I'm surprised to hear you say that when you biopsy people, you find a lot of AL, because if you look at published experiences, typically if the monoclonal protein screen is positive in these older patients, it's more commonly MGUS, but that's probably even worth writing up. But the point is, it's good that you're doing that, because those are the patients you don't want to miss.
Okay, thank you.
Thank you, Dr. Kittleson. Thank you so much for joining at the odd time. So have your breakfast and enjoy. So we'll move on to the next program. Over to Arun for the introducing the faculty and the student teams.
Great. Thank you so much. Have a wonderful day.
Bye-bye. Thank you.
We'll say there's a question from the chat box. We'll share it to you.
No, she has left.
So it's my pleasure to call upon the examiners for today, Dr. Jagammohan Tharan sir, Dr. Sudhir Kumar, Dr. Surendra Diora, Dr. Santosh Desh, and Dr. Shahir Ahmed. And the case presentation is by Dr. Kuldeep Gaur from AIMS Jodhpur, and the student panel from JIPMA Pondicherry constitutes Dr. Shiva Vignesh, Dr. Balaji, and Dr. Shahid. Over to the examiners, sir, and Dr. Kuldeep, you may please share your slides.
Very good evening, sir. Very good evening, all of you, all the respective faculties. Today, I will be presenting a clinical case. Can I start, sir?
Yeah, please.
Yeah, please.
Today, I will be presenting a clinical case of 25-year-old female from Jodhpur, Rajasthan, unmarried, studied up to 12th class, informing herself and her mother with chief complaints of bluish discoloration of lips and fingers on exertion and fatigue since 4 to 5 years of age. In history of presenting illness, patient was apparently asymptomatic till 4 to 5 years of age when she was first evaluated for acute febrile illness and diagnosed to have cardiac disease, but no further evaluation and intervention done from the family side due to without any reasons. And the bluish in history of presenting illness, since that first episode of acute febrile illness evaluation, the family started noticing bluish discoloration over fingers followed by nails, which was insidious onset, gradually progressive, which was initially at the age of 4 to 5 years, mild cyanosis, that too at heavy exertion, that is having light bluish tinge at the while playing with the peers and relieve with rest for about 5 to 10 minutes, which gradually progressive over her over 20 years to in between. Patient also have that cyanosis while she visited to some hill station for vacation, when she noticed a bluish tinge over the skin and lips, and she has to take rest for that. And now, over last 20 years, the cyanosis has progressed to moderate cyanosis, that is a deep tinge, a deep bluish tinge as per the patient description. That too at minimal exertion, that is while doing routine day-to-day activities like mopping the floors or bathing, and really it was relieved with rest, which was lasting for about 5 to 10 minutes. This bluish discoloration was also associated with fatigue, which was insidious onset and also gradually progressive, which was initially mild fatigue that too at heavy exertion, that is NYHA2, while playing with the peers and outdoor activities, that too progressive over last 20 years, to NYHA3, that is moderate fatigue even at minimal exertion like day-to-day activities, and that are also relieved with the rest. In negative history, I have for the bluish discoloration associated fatigue, I have taken a negative history to further narrow down. Like there is no history of recurrent lower respiratory tract infection or prolonged febrile illness, no history of failure to thrive, no history of chest pain or shortness of breath, no history of palpitations, no history of loss of consciousness, no history of convulsions, weakness of limbs or blurring of vision, no history of epistaxis, hemoptysis, no history of lower limb swelling. In personal history, she studied till 12th class, unmarried. She is a semi-skilled worker belonging to lower middle class according to modified Kuppuswamy scale. She has a normal sleep-wake cycle with normal bladder bubble habits, with no addictions, with regular menses and menstrual cycle. Among the maternal and birth history, the pregnancy was uneventful, without any significant history of drug intake during pregnancy. The child was born out of a non-consanguineous marriage with a full-term non-institutional delivery at home, while the neonatal period was uneventful as per the family, and child has not been vaccinated, with no physical, social, and psychological or motor milestone delayed, and she was third in the birth order. So, based on the history, the summary, a 25-year-old female with history of insidious onset, gradually progressive cyanosis and fatigue since 4 to 5 years of age, with which progressed over NYHA to NYHA2 to NYHA3 over last 20 years, with provisional diagnosis of congenital heart disease, cyanotic with decreased pulmonary blood flow. The physiological, the differential diagnosis is VSD with PS physiology. That is, first is tetralogy of Fallot or tetralogy of Fallot physiology, including DRV VSD PS, TGA VSD PS, CCTGA VSD pulmonary stenosis. The lower down the order, I want to rule out the Eisenmenger physiology also, and the variable presentation of Epstein anomaly as a cyanosis with neonatals, early onset cyanosis. So, to further narrow down the differentials, I want to have I want to proceed with the examination.
Yeah, we'll wait. We can ask your colleagues from JIPA because I think it's a very fairly concise history. What do they think about? What is their conclusion broadly? Dr. Balaji or whoever it is. Yeah.
This child actually had a cyanosis from 2 years of age.
Yeah.
If the child has survived from like till 2 years of age, one thing is that we can rule out some critical cyanotic congenital heart diseases. We can rule out like DTGA with VSD with significant PS and certain other things. So in this context, with the onset of cyanosis at 2 years of age and the person did not worsen rapidly over the period of years, I would like to keep classical TOF or TOF-like physiology as my differentials.
What are the critical cyanotic congenital diseases you want to explain? I mean, just briefly.
One is
they're not likely to be seen. I agree with you. Before post infancy, unless they are corrected or.
One is TGA with intact ventricular septum that cannot that wouldn't have survived.
You said TGA with intact septum is a very complex congenital disease. I suppose it's the easiest to treat. They are treated at the age of 3-4 days these days. Broadly.
Then try
yes. Cannot survive beyond infancy. What are those complex? You yourself said, no, complex.
TAPVC.
Yes.
Yeah, hypoplastic left heart, isn't it? It's hypoplastic left heart cyanotic?
Cyanotics. Yes, sir.
Yes. I think I should have told you this. All pulmonary atresia, all valvular atresias are cyanotic. Admission cyanotics. Oh yes, they don't survive unless intervened. So this patient has not had any intervention, palliative or surgical, corrective. Yes, so out, isn't it? And what about those asplenia, polysplenia syndromes? They are the ones which are not likely to survive beyond first 1 year. Asplenias invariably have very complex intercardiac problems, isn't it? They have common AV valves, pulmonary atresia. TAPVC, of course, is just, I mean, it doesn't matter because it's already admitted. They don't survive unless you can do something. Okay, then. Single ventricles, isn't it? All the single ventricle physiology, anatomy, or functional single ventricles in the absence of PS.
Yes.
They don't survive. You know, they not only become isotopic, they don't even survive beyond the age of. Unlike the usual acyanotic going on to cyanotic Eisenmenger, who saw increased peripheral flow already cyanotic in infancy, admission lesion. They have a very high mortality beyond 2 years of age. They're all Eisenmenger, but compared to the other Eisenmengers, as you know, of ASD, VSD, and PD, they have much more, almost 3-4 times. So they're not likely to survive at this. Okay, why do you think this VSD PS physiology he has, of course, enumerated all of them? I think he has not written single ventricle PS, if I am not mistaken. Yeah, I think you can add single ventricle PS also. Why are they likely to survive? He has given only 2 differential diagnoses. Some physiology, the other one is Eisenmenger. And of course, Epstein has to be considered in all cyanotic or even acyanotic congenital analysis. Yeah. What helps them to survive
Yes.
beyond the early childhood?
Decreased pupil.
PS physiology.
One is this.
Yeah, Dr. Kuldeep, you can,
Yes.
if 3 of them are not able to, you must have done some homework.
Yes, sir.
Yeah.
So
Sir,
What is this physiology which helps them? You can just tell. There are so many tetralogies or DRVs and with PSD, PS and all, they don't survive to infancy. So what is this your PSD, PS physiology that you're talking?
So basically,
What are those who are likely to survive? Yes.
presence of PS prevents this child to go into heart failure.
Optimal PS, right? To
Right.
assure adequate pulmonary blood flow so that there is some oxygenation despite the distal complex anatomy. Of course, which is the worst amongst all these? VST testosterone, which are less likely to survive up to adulthood amongst these tetralogy and variants. You know what are tetralogy variants? When you say tetralogy, there are also tetralogy variants.
Top pulmonary atresia.
No, pulmonary atresia, I told you, is an admixture lesion. Don't discuss it here. It has got totally different findings. Tetralogy and variants are
sir,
basically
absent pulmonary.
tetralogy with AV canal defect and tetralogy with absent pulmonary valve. Right? These are tetralogy variants. Will come under tetralogy. Then comes ultimately grossly different, DRV, TGA, but geologically the same. What is the physiology which is identical in all these 5 conditions?
PS.
There is large non-restrictive VSD with
Yes.
RVOTO, right ventricular outflow tract obstruction.
Not right ventricular. Say
PS.
pulmonary obstruction.
Pulmonary
It
obstruction.
is called subpulmonary obstruction because in a TGA or a corrected TGA, it may be a outflow obstruction, isn't it?
Subarterial, yes, sir.
Not subarterial, subpulmonary obstruction.
Subpulmonary.
Right. So whether it is arising, pulmonary artery is arising from the pulmonary artery, from the right ventricle or left ventricle, it includes everything. Right.
Yes,
so amongst this tetralogy, physiology, which are the ones which are likely to have a better, physiology, even amongst them, to survive to say 22 years.
Yeah.
Your total tetralogy is TOF, then DRB, VSD, PS. Do you want to classify them into 2 types? Depending upon which you have a better survival?
Subaortic VSD.
Yes. Why? It has got a better survival than subpulmonary VSD?
Streaming, sir. It is favorable streaming.
Huh?
Streaming. One is it will be having like favorable streaming. Second thing is incidence of heart failure is lesser with subaortic VSD.
I don't know. I'm sorry. I'm not able to hear.
Streaming, sir. Favorable streaming.
Favorable streaming. That is what.
Right. Oh, you are talking about favorable streaming. What is favorable streaming?
Means like pulmonary venous flow goes into aorta.
Yes.
And also
Pulmonary
the
venous flow goes into the aorta rather than going into the pulmonary arterial recirculation. It is wasted pulmonary venous flow. Good. So obviously, DRV VSDPS symbiotic. VSDPS has a better functional anatomy, right? Okay. What about TGA VSDPS? Amongst them, it's probably the worst, isn't it? Yes, it is. DRV with subpulmonary VSDPS or a TGA VSDPS are worse. For the same amount of pulmonary blood flow, they have much more arterial desaturation, right? Because of unfavorable flow, favorable mixing in the heart. What about corrected TGA VSDPS?
Systemic LV.
it is a better survival. It will have like decreased. The PS will.
Yes, actually, corrected TGA VSDPS also has favorable streaming. So for the same amount of pulmonary blood flow, they will have as much arterial saturation as a classical tetralogy. But of course, burden with what? Burden with right ventricle?
Failure, like systemic RV.
Yes, with an abnormal left-sided AV valve. Often it may get reagent, but of course, it's extremely rare when there is VSDPS for the left-sided tricuspid valve to be regurgitated. Right? It's a protection. The PS is a protection for the left-sided tricuspid valve of the right ventricle. The left side right ventricle and the right side. It is most often competent. Okay, so we have now. What about Eisenmenger? What are the Eisenmengers you are considering?
Sir, post tricuspid.
Cyanotic from say 5 years of age. I don't remember.
It's a 25-year-old female. Cyanosis since the 4 to 5 years age. 4 to 5 years.
What age did she recognize cyanosis?
Sir, 4 to 5 years of age.
Okay. So what are the Eisenmenger physiologies that you would consider?
Sir, post tricuspid shunt with the Eisenmenger physiology, sir. Like sir, large VSD.
Yes.
And sir, patent ductus arteriosus.
Because recognizing cyanosis in the upper limbs, usually they don't look at the lower limb, they look at only upper limbs. So obviously differential cyanosis they wouldn't have recognized.
Large VSD.
PDA would come if your answer is correct, it would go low in the list. Isn't it?
Yes,
you
sir.
don't get desaturation in the upper limbs in PDA typically. So there may be some exception. Yeah, next. Any other? What are the post tricuspid? You didn't exhaust yourself.
AP window, sir.
Huh?
AP window.
Yeah, AP window. And along with VSC, you should always say endocardial cushion defect also. Because it's also an acyanotic, which goes on to Eisenmenger much earlier than just a simple VSC. Eisenmenger endocardial cushion defect with VSC and pulmonary hypertension, or a large VSC with pulmonary hypertension. Of course, single ventricle and those admission lesions, they don't survive at disease. So I don't think we need to discuss. I think you have to differentiate between the VS physiology against the Eisenmenger physiology, right? And abstinence, what are the clues which you might suspect there is abstinence?
Sir, either like neonatal cyanosis or infantile heart failure, the patient gets
Biphasic presentation. They are invariably cyanotic at birth simply because that our right ventricle cannot pump against a non-rigorous pulmonary vasculature. The early infancy, in the neonate, as the pulmonary hypertension regresses in the lungs of the neonate, the cyanosis usually becomes less, especially in the moderate or mild form of abstinence. Right. So it's a bimodal. Then again, as age advances, the right ventricle would fail, the TR would become worsen. Again, right left shunted age. Okay. Any other things like, somebody must say whether it's a pulmonary arteriovenous fistula or a pulmonary artery to LA fistula or an IV SVC connected to the LA. Do you think you will consider any of this?
So they are under near normal pulmonary physiology, basically, and not decrease pulmonary blood flow.
So your history, you're not seeing the patient, no? It's only history. Does the history rule out all these possibilities? This I'm asking. Very nice. SVC to A connection. We're not talking about the IVC streaming, that it's okay. We will not talk about that. Actually, it also comes like, rugged type of ASD. where cyanosis is only a minor component, isn't it? The right to left shunt is a minor component of a left right shunt ASD. So these are the things you can keep low in the list along with Epstein's, right?
Okay, sir.
Okay. Right, please. Just
We had a wonderful discussion on that. I have a few comments on or stretch that discussion on history. I was not very happy because you made a very lengthy discussion, not needed. You can say this patient has cyanosis detected in the upper limb and lips from this thing. It was in serious progress like that. But to differentiate these things, you have not given any points. Now, everything can be discussed because the only thing in the history was cyanosis and fatigue. So that means this patient has a right to left shunt. And what is the reason for that fatigue? The cardiac output may not be adequate. Okay, obviously, cyanosis also results in fatigue. But we didn't go into the details of the history of the early infancy and some negative things. You said so many negative things. You need not stress like that. So, from the history, we did not have anything to support any of these things other than saying that this is less likely to be a critical lesion which is likely to survive. There was one question from that is from the audience, which are the things which are less likely to survive. So the survival depends on the saturation, the cardiac output, and whether there is a problem with the pulmonary veins. So these are the things which determines the survival in any congenital disease, especially the cyanotic congenital disease. What is the degree of saturation? What is the cardiac output? Pulmonary venous pressure. The pulmonary artery pressure as such in this cyanotic heart disease may not significantly modify because the pulmonary hypertension, as Professor Jagan has said, it's a relatively late phenomenon. So you should have started from saying, apart from that, what was the history in early infancy, that you should say that there was no history to suggest a heart failure, like increased precordial activity, recurrent respiratory infection, feeding from, all those things should be stressed. Because if it was there, Professor Jagan would have also considered complex conditions which produce Eisenberg situation. As he has rightly pointed out, even though severe pulmonary hypertension can occur in complex VSDs, especially large VSDs, AV canal VSDs, or VSDs with Mongolism, or things like that, they can have development of pulmonary hypertension quite early, so that they can have Eisenberg quite early. So what we should concentrate on those negative things you have said is infancy history is very important. Where the pain. Then second thing you should have said about no step cyanotic spells. I didn't hear that. I don't know whether you have mentioned that.
cyanotic spells he didn't mention, but other thing, absence of any symptoms. Actually, he said absence of any symptom, but I think he should have probably said no history of cyanotic spells and no history of heart failure. He said no history of heart failure and symptoms of heart failure. Yes,
I didn't listen to that because he said so
cyanotic
many
spells
negative
he
history.
didn't mention. Maybe he should
Negative
have.
history, and for the examination spatting also you have to say any history of spatting or not. That is, I think that may not be very relevant when you discuss these things, but there are two components in this thing. One is basic exam, second is knowledge. The basic exam, the examiners want is heart failure in infancy, failure to thrive, increased precordial activity, all those things in infancy, then cyanosis, squatting spells, these things, then the developmental thing, then the family history, you have put it very rightly. Now, from the history, we don't have much clues to the physiology of this situation other than there is a right to left shunt. Okay. Now, if I ask you the same thing, because to reinforce this thing, to say that this is a low pulmonary blood flow group, we did not have any strong historical support apart from statistics. So we go by two things. What Professor Jagan said is, which are the cyanotic congenital disease which are likely to survive up to this age group, relatively mild symptom. We have been telling that the symptoms can be mild. So that is the way we look into. So the one which survive like that for a long time, with cyanosis detected early in childhood, will be the tetralogy like physiology, which we have discussed very properly. Regarding the other thing, Eisenberg physiology, he has put it very rightly. Even though Eisenberg can occur in complex heart diseases, like we put it as complex VSDs, they can present with a cyanosis and they can present, especially complex VSDs with severe pulmonary hypertension, can present early with cyanosis. The classical VSD, even though they develop pulmonary hypertension or reversible pulmonary vascular disease from early childhood, I don't know whether they present with cyanosis by 4 years. I have not seen, but theoretically possible. If I ask you, is it Epstein's anomaly? Because there are only two things: cyanosis detected and then fatigue. These are two things. So whether you would put Epstein, where will you put Epstein anomaly? As Professor Jagan has said, any cyanotic angina disease, we have to bring in Epstein's anomaly, and probably single ventricle with different physiological variants have also to be considered. Then what about the other thing? Because certain things which are rare or less common should be considered, because we don't have any clues for Eisenmenger or a low flow group like that from your history. Okay. So I think overall it has been well described by Professor Jaganmohan. I don't have much to add, but if you have some questions at this level, we can answer.
I'll also just add, because I was only giving my comments on his. Of course, you should also think of pre-tricuspid cyanotics, right to left shunts, admixture lesions. I mean, TAPVC is common atrium. I think everything would fit into that also. He said they would be cyanotic anyway because they are admixture lesions. And over a period of time, common atrium is basically a large ASD with also some added mitral regurgitation. They would become symptomatic much earlier than a classical ASD. And TAPVC, of course, we are not talking about the obstructed TAPVCs because they don't survive beyond 1 year. If you know the natural history, TAPVCs, 80% of them die by 1 year. Of course, larger percentage of them are due to obstruction, but even a small percentage, it's functional obstructions, right? They may not survive the early infancy. It's only 10 to 15% survive beyond. But you should have probably kept that also amongst your increased pulmonary blood flow, like TAPVCs and single atrium, because they don't need to have been Eisenmenger now. It could have been still pulmonary hypertension with right left shunt, left right shunt, depending upon the findings. So I think that also you should just keep in mind. Otherwise, would I miss
we have to consider
important component of differential diagnosis? After all, your history is very non-specific. Cyanosis detected at the age of 2 or 3 years, so that doesn't really help much. Shall we go ahead now?
I think you may not be able to pinpoint the diagnosis because of lack of contributing symptoms.
Yes,
now, to expand that, large ASD with deroofing of the coronary sinus to the left atrium, they can remain minimally symptomatic and they can have cyanosis. That's it. So here we don't have much symptoms to point out to these are the possibilities. So I think you have to discuss almost all the possibilities, starting with what Professor Jaganmohan has initially said, the things which are less likely to survive. That should be excluded first. Then we don't have any clues for any other thing. So we can discuss all the possibilities with a favorable pulmonary blood flow, favorable saturation, favorable cardiac output, and no pulmonary venous congestion. That is the way I proceed. Professor Jaganmohan, can we give some time for them to ask some doubts on this thing? If they have some doubts.
I have no problems. Yeah, please. You mean from the audience
or from the audience or from the panelists? We have some doubts, we can answer or we can discuss that rather than we always talking. We have one more faculty.
Dr. Mayank is there. Dr. Mayank, you can also join.
Yeah. I didn't see that. That's why we.
I think he mistakenly joined the other.
No, sir. I have joined, sir.
Yeah, you can join the discussion, Dr. Mayank.
Yeah, definitely. So actually, sir, what I have seen in this patient, the history is very atypical. She has not given very typical symptoms. On provoking, only be able to drag some history, like some history of cyanosis, which was noticed after she has gone to some clinician and he told like she's having some heart issues. After that, only the parents started noticing that cyanosis on exertion. And they have told that in between while playing, she used to sit in between actually to take rest. So I think some cyanotic squatting episode maybe or may not be there. I am not sure. And in between, she was totally asymptomatic and they didn't take any clinician or any advice also. So now she came with some worsening of the symptoms which was she is having previously. So that much only she gave actually, sir.
Yeah, I think that's fair.
This one
you can still bring in some more condition like all pulmonary atresia with VSTs because at birth they do have a substrate for aortopulmonary collaterals, and the minute there is hypoxia right from birth, the aortopulmonary collaterals start developing, and so they have got a good chance of surviving to mid-adolescence and beyond. So that's a good group which can survive. I'm not talking about the intact septum pulmonary atresia, which do not survive beyond 1 year because they are vectors dependent.
Dr.
There are
There's
a lot of
question in
conditions
the
which
chat box.
we are not actually enumerated, but I think pulmonary atresias with PSDs also you can bring in. Of course, squatting, basically it only means that you are improving the blood flow by increasing the afterload of the left ventricle or the systemic circulation impedance. So even Eisenmenger may get some relief with squatting. All tetralogy physiologists, so typically tetralogy will get better, some relief with squatting. There's no doubt about it. I think
there was a question in the
question in the chat box.
There was a question, sir, Chopra sir.
No, there's a question. What would be the history in cyanotic congenital heart disease with reduced pulmonary blood flow versus increased? Okay, so I think quick answer.
I think that we already discussed, isn't it? Cyanotic congenital heart disease. I think you can't use such common words like that. Because cyanotic can be acquired over a period of time. But if you're talking about cyanotic congenital heart disease from birth, right? Cyanotic congenital heart disease from birth, it can be increased pulmonary blood flow or decreased pulmonary blood flow. Decreased pulmonary blood flow, usually cyanotic spells, and as the child grows, or even the squatting equivalents, and as the child grows, the spells may become less. But squatting and squatting equivalent postures will be there. But there will be certainly no features of heart failure. Only one condition where you can have a heart failure initially, it's a grassroots type of VSD, which is actually a large VSD with a malaligned VSD with a potential RV outflow obstruction, which rapidly progresses to significant RV outflow obstruction, so that right to left to right shunt in the infancy soon becomes a cyanotic with a reduced pulmonary. It's a very rare thing, results that you should know. Just because somebody asked me this. Otherwise, increased pulmonary blood flow, cyanotic with increased pulmonary blood flow, I think we have got a lot of conditions. You can remove the PS from all this, then all will be increased pulmonary blood flow. It can be DORV, transposition, corrected transposition with VSD, single ventricle. All of them will have features of heart failure, right? And unless something is done, a single ventricle with pulmonary hypertension, they become inoperable by three months of age. So you have to do a very early PA ban. Otherwise, the pulmonary vascular disease will not permit even a Glenn shunt. Forget the fountain. All others will have to be some palliation should be done, either banding or correction before the age of 2 years. But they'll have features of heart failure with cyanosis. While acyanotic, like a large VSD AV canal defect, they will have features of heart failure, but the cyanosis may not be an important because they're not by birth cyanotic. I hope I have been able to answer the question.
Yeah. I think basically this case, one is when you don't have much symptomatology to point out or to take different diagnosis, you should be able to discuss all the possibilities.
Yeah,
that's the issue in this case. So
Yeah,
we'll be assessing your knowledge in cyanotic congenital disease as Professor said, whether it is a cyanosis from early childhood or cyanosis appearing later, to differentiate. Second thing which helps us to differentiate or to shortlist will be the patient has been evaluated, was something done for this patient. For example, TAPBC will not be left like that. TGA will not be left like that. So we have to ask whether the patient has been, that also you have to take the history, because we have to have some differential diagnosis. There should be something to sort out these things. So when was he evaluated? What was the method by which he was evaluated? Whether he was asked intervention or not. Then suppose the patient was evaluated and no intervention was done, then certain things are excluded from the list of things which we have discussed. But basically, I think we have to know this case. It is a little difficult for the postgraduate because we don't have a clue to have the different diagnosis or shortlisting this thing. So you should go for all the things, starting from the statistics, then the common things, low flow, high flow, all those things, and almost all the things in the order of preference you have to type. Okay?
And go on to
go to the
physical findings.
Physical findings now?
Yeah.
Please go ahead.
To proceed further, to narrow down the differential diagnosis with general physical examination, Patient conscious oriented with the central cyanosis present over lips and the tips of fingers and the tip of tongue and fingers, and grade 2 digital clubbing was there. No icterus, lymphadenopathy, pedal edema with BMI of 16.2 kg per meter square, with upper segment lower segment ratio of 0.98 with pulse
But to
of
make it
6.
simple, you can say that is uniform central cyanosis, where somebody may ask you, what about, did you look for that? And oxygen saturation, you can tell straight away. Okay, go ahead.
With
At that
pulse,
point, you can talk about oxygen saturation.
okay,
Okay, fine. Go ahead. Next.
with pulse rate of 64 per minute, regular rhythm, normal volume with normal character with no radiofemoral delay, with blood pressure of 104 to 72 millimeters of mercury in left upper limb and 100 to 100 by 70 millimeter of mercury in right upper limb, and with no significant difference in upper limb and lower limb, with respiratory rate of 17 per minute thoracoabdominal, with JVP was not raised, with the no without despite abdominal reflex, with saturation of 82% without any significant difference in any of the four limbs.
Okay, so these physical findings, did you suspect something, or it's just a usual, except cyanosis, nothing else is there?
Yes, sir. A cyanosis and a grade 2 clubbing.
Yeah, no, that's okay. That doesn't really help.
Cyanosis, yes, sir. Yes,
So
sir.
what about heart rate being 64? Think, do we think this patient has some bradycardia related heart disease, or you think it's okay?
So the patient was
So
relaxed.
you're saying that rate is
He's
important
symptomatic.
because
No? He's
JVP you have to
symptomatic. If
contribute.
efforts in class 3 heart rate, I hope you're not missing any sick sinus syndrome or heart block, because that gives you some clue as to what the underlying disease may be. That's why I just want.
Yeah. JVP you should have mentioned not only the wave factor you have to tell. Because that is one thing. Because as Professor Jagan said, you should have some idea about the cardiac rhythm. So if you say it's a normal waveform, which is 64 per minute, we conclude it is a sinus rhythm at a relatively slow rate. But before that, you should have discussed whether there are any skeletal abnormalities or syndromic features. That you have to tell negative things. General examination, the first appearance you have to tell. Because that may give you some clue regarding the disease, especially common entities. Okay. That is more important. This is fine that BP, you need not spend too much time on all the four limbs. Unless there is some clue, one upper limb and one lower limb may be enough.
Yeah, that's
Unless
all
there is a
standard things.
gross.
I think, yeah, they should save the time for better things. I think that's correct.
Yeah.
Okay,
Fine.
good. I think we.
Go ahead.
Let's see.
On CVS examination inspection, chest was bilaterally symmetrical with no evidence of any pericardial bulge. With apical impulse was not visualized in this patient. Was no visible pulsation or any scar mark.
So relatively quite hard. Fine. No cardiomegaly. Fine. Good.
On palpation, the inspection findings are confirmed. The trachea was central in position. The apical impulse was on palpation ill-sustained and diffusely localized over two intercostal spaces over left 5th to 6th intercostal space. That is 1.5 centimeter medial to mid-clavicular line, with no evidence of any palpable thrill or any parasternal heave or any epigastric pulsation or any palpable heart sounds.
5th to 6th, you may find it a little difficult with the examiner. So you say 5th or 6th. Don't say 5th to 6th. Okay. Don't invite questions from our side. Okay. Go ahead.
On percussion, the findings were situs solitus, levocardia, with left head border corresponding to apex and right head border corresponding to retrosternal, with upper border of liver dullness was percussed on the right 5th intercostal space in the mid clavicular line, with left 2nd intercostal space is resonant on percussion.
So before going to auscultation, you'd have some idea. 90% of the information you have to make or assessment you have to make by this. So you have concluded that this patient has uniform central cyanosis with a saturation of 82%. He is in sinus rhythm. There is no congestive heart failure. Then levocardiositis solitus. There is no cardiomegaly. There is no RV. Now what you have to see is whether the ventricle is normal, RV dominance, LV dominance, or biventricular. What is the pulmonary artery? What is the great artery relation? So these are some of the things. So these are the things which you have to make sure by palpation or percussion. Because auscultation will be usually monotonous, seldom contribute to your diagnosis. So here is a patient who has a normal heart size with quiet precordium. The important thing is, what about the right ventricle? What about the left ventricle? It is very unimpressive. Okay. There is no pulmonary hypertension. There is no pulmonary artery dilatation. And the great arteries, we don't know, but there is, which is excluded by looking at the great arteries. the L-post diuta is not there because there are no pulsation in the left anterior chest. So these are the things. Absence of pulmonary artery pulsation doesn't mean that the pulmonary artery is not dilated, because we don't know whether it is the real transmission or not. So that is a picture, radiological picture you have got in this. The heart levocardia, situs altus, cardiac size is normal, the main pulmonary artery is not prominent, and there is no L-post diuta. So these are things. The only thing which you are not getting is what is the pulmonary vasculature. Now, ordinarily, it indicates that this is a normotensive or hypotensive pulmonary vasculature. But if there is classical transposition, it may not be, because the pulmonary artery is posterior. That's the only problem which you are facing. Okay?
Yes.
Auscultation.
Okay. Yeah.
Then proceeding to auscultation, the S1 heart sound is normal. S2 is single and loud A2 with no LVS3 or ejection click sound. On murmur was grade 3/6, early peaking crescendo decrescendo pattern, ejection systolic murmur, heard in left 6 to second to third interparasternal region, best heard with the diaphragm of the stethoscope, increase on squatting with no variation, without any variation is respiration or Valsalva.
That is what you expect ordinarily. Okay.
Yes, sir.
Then another system.
Can you just go
Yes,
back?
sir. Yes, sir.
Just the rejection systolic or something. It's early peaking, late peaking.
Yes,
He
grade
said
3
early
by
peak.
6.
Oh, you are written. Sorry. Okay. Okay. Yeah. Early peaking. And
But length is
yes.
important. Length of that murmur is important.
and length also.
Sir,
Length.
Is it going up to the that A2, whatever, because you are not hearing the P2?
is a grade 3 by
Is it a,
sir,
is it
crescendo
relatively short or relatively long murmur? That's the number one thing.
sir, yes, sir. Brief murmur.
Pardon?
Sir, short duration murmur, brief murmurs.
So it's a
Okay.
short and early peaking systolic murmur. You
Yes.
can call, yeah, you can mid systolic murmur, whatever you want to call it. Okay. Good.
With
Any
the
other?
other,
There is no ejection click, isn't it?
yes, sir. Yes,
And
sir.
no early diastolic murmur. I think it's good to write all this because we might ask you some questions later. What is the cause of this early diastolic murmur we are asking about?
Sir, top with absent pulmonary valve variants, sir, with
Yes.
having early
More
diastolic
common
murmur.
in top.
Yeah. What type
More
of
common.
early diastolic murmur do you get in that?
Sir, top with AR, sir.
What is the difference between the two murmurs of absent pulmonary valve murmur of PR and iotopathy with tetralogy with the AR? What is the difference in the quality of murmur? Very
Sir,
easy. I mean,
Or you have to look at the EDM in a cyanotic angiolysis, that is aortic, pulmonary, or truncal. These are the three things which you have to look into. Aortic, truncal, and pulmonary. Pulmonary could be hypertensive or normotensive. In broad approach to early diastolic murmur in cyanotic angiolysis. Okay, sir.
yes, sir. Sir,
okay.
sir, in other systems, sir? In other system, there was, sir, in respiratory system, there is no significant finding. In abdominal, there was no significant finding.
You
In
have to say
CNS,
there
there
are
is
no
no
continuous murmur in the lung fields.
lung
You have to
fields
say
and
that.
no
Situs,
evidence
you
of
have to say.
focal neurological deficit or any cranial palsy in the
Okay,
CNS
fine.
systems.
Fundus, did you look into? Because we may not do
Sir,
a detailed examination, because you have to look at the fundus in patients with cyanotic heart disease. For exam purpose, we have to do that. And a quick examination to see whether the patient has a subclinical stroke or not. Because the cyanotic angiolysis, you need not go into all the details. Maybe quick facial palsy, some movements, and reflexes and plantar you should look
Plantars.
into. That we are likely to, because you can spend 2 minutes or 3 minutes in the central nervous system, will be fundus, quick evaluation of the cranial nerves, especially the seventh nerve, and reflexes and plantar. That's all what is needed, because there is no history. But subtle or subclinical or mild stroke, they may miss. The patient might have had headache, where the patient might have had a problem, but they might not have given significance to that. So that is important. Okay.
Okay. So let's go to the next slide.
With this history and examination with this patient, a 25-year-old female with history of
Yes.
insidious onset, gradually progressive cyanosis and fatigue since 4 to 5 years of age, which progressed over NYHA 2 to NYHA 3 over last 20 years, with examination findings of central cyanosis, clubbing, grade 2 clubbing, RV type apex with single loud A2, with grade 3/6 early peaking crescendo decrescendo ejection systolic murmur at left second to third intercostal space, with the
But why do you say it is RV type apex? There is a problem here. You are telling that there is an RV type of apex.
No,
We
I
are
don't
not
think so.
sure about that.
He didn't say RV type of apex. What did you
He
tell
has
about the
written
apex?
that RV type of.
RV
He has
dominant.
written RV type apex.
Dominant.
Okay.
So that's a problem because that's the important thing. So once you say it's an
Wow.
RV type apex, then we exclude certain things. So we are not sure. We can say there is no
Fair
cardiomegaly.
enough. Good.
Fine. Go ahead.
Sorry, I missed that.
Go ahead.
With provision to the diagnosis of situs solitus levocardia, cyanotic congenital heart disease with decreased pulmonary blood flow, VSD, PS physiology, NYHA3, a functional class with normal sinus rhythm, with no evidence of congestive cardiac failure, infective endocarditis, or any cyanosis complications, with provisional diagnosis of tetralogy of fellow, DORV with VSD with PS, TGA with PS, VSD with PS, and CCTGA with VSD with PS.
Shall we ask the panelists to discuss on that thing, their views on this thing, their opinion regarding the different diagnoses, rather than we just discussing whether you agree or disagree, whether you have some other different diagnosis, and how, what about the professional diagnosis, which are the things which you would like to consider, exclude? Okay.
Initially, we had a broad, history was not giving us any pointers. Now, obviously, things are quite straight, isn't it? Not a very large heart, almost normal cardiomegaly, and just one murmur. And the second sound is single with absent pulmonary component. Yeah.
More likely to
And
be
A2 is low. So we can
Yes.
think, okay, I think almost all of us will straight away go for a tetralogy of fellow equivalent and tetralogy of fellow as the first thing because there's a commonest cyanotic congenital with low pulmonary blood flow growing up to this level. The questions will be same thing. Now, how to differentiate these things? That will be the question clinically, or which are the things which are less likely you can straight away say, and how to differentiate the other things. That will be the approach. Okay, because the ventricle we are not sure. Even
That's
though
correct.
we said
You
it
could
is
you
the right
could-
ventricle, we are not sure about the ventricle.
You could add even single ventricle with PS, but
Yeah.
it doesn't matter. Can you tell us
Yeah.
how you would have tried to decipher which one of these is most likely? How would you have excluded corrected TJ, VSD, PS? Simple question.
That's it.
Sir, based on examination, sir?
The panelist.
How you have got yeah.
One is L-post data can be part of CCTG.
L malpost
Louder,
aorta.
please.
That means a pulsation in the
And
third
then-
space with a loud palpable sound. More
Yes.
likely to be aorta, isn't it?
Yes.
Because you can have so many other reasons why you can have a pulsation, like, Epstein's also can have. But a loud second sound along with the pulsation, you should suspect. So that is the one where it is corrected TJ almost always has to have an L malpost aorta. Single ventricle, the ones which survive generally have an L malpost aorta. So that also is probably excluded. Now comes to TGA, VSD, and tetralogy and DOR. What about cardiomegaly? Do you think any of them could have cardiomegaly compared to one against the other, which are likely to have more cardiomegaly than the other?
DORV can have.
Huh?
DORV
Are
can
we
have.
almost
See, for the same cyanosis, amount of cyanosis, the pulmonary blood flow is less in tetralogy of Fallot because it's favorable, isn't it? While TJ will require much more pulmonary blood flow to have the same cyanosis because it's unfavorable. So they have to have cardiomegaly. Anything causes increased pulmonary blood flow in post-tricuspid, you should have cardiomegaly, ventricular dilatation, whether it's single ventricle, transposition, whatever. So if there is no cardiomegaly at all, right, then with this saturation and this pulmonary blood flow, whatever it is, tetralogy is probably ahead of TJ, VSD, PS. The next, almost like a cousin brother of tetralogy is
DORV.
URB,
Sub-by. You have
VSD
to
with
tell them.
symbiotic VSD with PS. It's very difficult clinically to differentiate tetralogy against DORB with symbiotic VSD and PS. They almost would come together, right? So theoretically, tetralogy would have a better saturation for the same amount of pulmonary blood. You understand? This is a favorable and unfavorable streaming. So lack of total, actually tetralogy has the smallest heart amongst these tetralogy physiologies for the same saturation. It will have the smallest heart, right? So if the heart is small and saturation is quite good compared to the others, then tetralogy comes first. And of course, we are not talking about PSPR, absent pulmonary valve. Endocardial condition defect with tetralogy also usually has an AV valve regurgitation murmur, which you should pick up usually because it's a step. I think without more than this, I don't think I can discuss much. Dr. Suday or
I think after the
After-
findings, certain things we have to explore. But the point is, what is point against tetralogy of FLO? Nothing. Okay, because statistically one, the normal heart size or no cardiomegaly, quiet precordium, RVOT murmur, single second zone, and loud aortic component because the aorta is relatively anterior and large. Fine. So there are no points against that. Next question, as I also thought, whenever you have tetralogy of typical, the immediate differential diagnosis will be a double tritriple with subaortic VSD. Don't say VSD. We have to clearly say subaortic VSD with pulmonary stenosis. Then TGA with VSD PS comes low in the list. Because if you look at the X-ray also, if you have seen in spotters, you might have seen X-rays of the DTGA. There is a relatively large heart. It is not a small heart. You have a narrow pedicle with a relatively large heart. I'm not saying huge cardiomegaly. Among the cyanotic disease, as Professor Jagan has already said, the smallest heart is for tetralogy of heart. Okay, the largest heart is for Epstein's, obviously. Then the smallest pedicle is for transposition of great arteries. And the broad pedicle, apart from Eisenmenger, will be L transposition because the great artery is malpost or L post. But when it comes to malposition, it is different. So if I look tetralogy of Fallot, DR with subaortic VSD, then in the examination, because we will teach you for examiners, some examiners will ask you how to differentiate soft findings. There is something which is important is the murmur will be a little higher in the DRV, and you may be able to hear the P2 because the level of obstruction can be different in tetralogy of Fallot versus DRV. That's the only thing for examination, but I don't think that clinically it is possible to differentiate between tetralogy of Fallot with DRV with VSD. And DRV subaortic VSD. Transmission of great arteries, as we discussed earlier, the sinus will be earlier. If the pulmonary blood flow is less with smaller heart, the sinus will be deeper. That's the important thing. Despite cardiac mixing, there is transmission. The cyanosis and the pulmonary blood flow are important. In tetralogy of Fallot, it is straight inversely related. As the cyanosis comes down, the pulmonary blood flow comes down, cardiac size will be smaller. Whereas as he has rightly pointed out, in transposition, if they survive, the saturation will be better, indicating that despite this intercirculatory mixing, the pulmonary blood flow is reasonable. So that the heart size has to be mildly large. Tricuspid you should be careful. You should be careful because in a tricuspid survives, you may not get a typical findings of a prominent AV because prominent AV occurs only when there is a non-restrictive ASD. And if it is a non-restrictive ASD, the patient may not survive, the patient will be deeply cyanosed. Then the LV apex also again depends on the pulmonary blood flow. So you may not, the classical finding which we teach you like A wave, LV apex, and mitral MDM, seldom you get in the classical type 2B tricuspid atresia. Okay? There is no parasol here, so you can't exclude that. Now, TGA with PSDPS, corrective transmission, we have excluded. Then I may discuss single ventricle because many times we have seen single ventricle with pulmonary stenosis mimicking tetralogy of Fallot with a reasonable pulmonary blood flow, they are surviving. Then as Sir has said, AV canal defects with this thing, though we can discuss, usually they will have AV valve regurgitation, so the heart size will be a little more. The RV will be, precordium will be a little more dynamic. Theoretically, it is possible. So many other things can be excluded. Am I right, Professor Jaganmohan?
Yeah, I think so. I don't know about this tricuspid atresia. Usually we now discuss tricuspid atresia is to be discussed as a separate chapter in the 80s. Today it is only part of single ventricle with one AV valve patent, the other one is stenosis. Usually there are several types of tricuspid atresia. We are talking about survival is only tricuspid atresia with restrictive VSD and or
Pulmonary
stenosis.
So one point in favor of that.
VSD itself can be the cause for reduced pulmonary blood flow. They are the ones which
and that's the main cause, am I right?
Best for survival. Okay.
Restrictive
So
VSD
there,
is
of
the
course,
main
you'll
thing
get a
because
clear left ventricular apex. Shall we now go to the next?
The pulmonary blood flow is mainly determined by the size of the VSD in tricuspid, am I right? And the murmur
normally
of
related
VSD.
In normally
and
related.
I think if you get a cyanotic disease like a long murmur, which may indicate a left flow across the ventricular subluxation, that is one situation again you have to suspect. If the murmur is relatively down, despite significant CNOs, that is one thing where you can suspect.
If you get a pansystolic murmur, you should suspect a tricuspid atresia because restrictive VSD obviously gives a pansystolic murmur than an ejection. I don't split hair on this ejection and pansystolic.
Yeah, I agree.
it's not
But some
clinically
examiners may ask
possible.
these questions.
Yeah.
Some examiners may ask these questions because there are
If
two
you
levels.
have a
One is
theoretical question, you
just
should answer.
yeah.
That's all.
Fine.
Next.
Any
So-
panelists, anything you want to ask? Any points you want to clarify? You want to contribute? Because we have been discussing. You can ask doubts also because you get seldom a chance to get this type of discussion, especially from persons like Professor Jagan Mohan. So you can ask. No, I'm not joking because I've learned a lot from Professor Jagan Mohan from my PG onwards. You have something to ask, you can ask. This is one session
We'll go
where
ahead.
we'll.
Let's
Yes.
go to the ECG, sir. I think
ECG.
we are 8:20. Yeah.
To further narrow down the differentials, we proceed with
Oh,
the
it's very
investigations.
low heart rate. Yeah, of course. Somebody has asked again low heart rate. Now, as I said, low heart rate, normal JVP excludes complete heart block, right? In complete heart block, the JVP will be showing cannon wave. So lack of in a normal JVP with both A and B, basically I think it is sinus bradycardia. If you believe that the pulse volume is regular as well as the JVP is normal, it is sinus rhythm only. If it is atrial paralysis, then you will not get an A wave. If it is complete heart block, you will get cannon waves. So I think it is. I'm quite convinced. If findings were right, it is just a bit of sinus bradycardia. Okay, let's go ahead.
So to further narrow down the differentials, we proceed with the investigations, ECG,
Yeah.
chest X-ray, echocardiography in the order.
Quick.
With the this is 12 lead ECG.
Don't say in that order. Some examiners may not be happy because we will ask you what are the information you get from ECG, what are the information you get from X-ray. Because some examiners may say that basically our initial approach is what is a pulmonary vasculature. What is a pulmonary vasculature? ECG may give us an idea about so many other things. So some examiner, but you say that I will go for ECG, X-ray and echo. Okay.
Okay, sir.
ECG.
So, ECG, this is 12 lead ECG with normal standardization with the amplitude of 10 mm per millivolt with running at a speed of 25 millimeter per second.
Okay,
with
fine.
the
What are the information they
with-
obtained from this ECG?
with
What are the
heart rate,
information they
yes, sir,
obtained from
with-
ECG? Points in favor, points against, excluding or supporting. That's all what we want at postgraduate level.
First is a
Yes.
normal sinus rhythm, that is ruling out the CHB, any heart blocks, and
Yeah.
the right axis deviation of around 110 degrees. So in the
Right.
favor of the top, and then sir normal P wave with normal duration, no prolongation of P wave, or normal any prolongation of PR interval, again ruling out the
Good.
heart blocks.
So
Good,
RV
good.
dominance,
RV
RV
dominance with
dominance, there is no conduction abnormalities, no
Yes, sir.
arrhythmias.
no
So
And
the
about the
axis is
precordial
normal,
leads, you
RV
can just
dominant.
highlight because it seems like a classical ECG. Yeah, precordial leads V1 and V2.
Yes, sir. The V1 showing the tall monophasic R wave with abrupt transition from V1 to V2, showing in also the V5 V6 showing this the persistent R waves, that is adequate pulmonary blood flow and LV filling.
Yeah, even if there are Q waves and adequate R waves are indicator of pulmonary blood flow because that is the one which keeps the LV developed. Yeah, good. So this is fairly straightforward for tetralogy. This doesn't really require any other differential diagnosis unless you get some surprise on the X-ray. Let's see the X-ray.
And echo. But can it be LTGA from this ECG? Can it be LTGA from this ECG? Somebody may ask that question.
So right axis
I was about
No, you
to
can't
tell that
say. You
QS,
can't say. You
V5,
can say
V6,
that.
but
sir, points in favor, points in against. Point against, sir, that is left axis deviation with no evidence of any heart blocks or any CHB.
Okay, fine. You can say certain things we can exclude. If there was an AV block, you could have considered that. Left axis in a cyanotic angiogenesis, that may be a question that will be asked. A tetralogy of fellow-like situation, but the axis is left. What are the possibilities there? Because we have to ask some questions to you. You should know also electrocardiogram. Though it looks typical, what is the RV pressure also? They may ask. Does it help you in some way? If the STT is normal, that means RV pressure is likely to be systemic. Now, axis they may ask. Now, heart block we know, but axis in a tetralogy of like situation, how does it help you?
Sir, no,
Right axis, extreme
you
right
can ask,
axis.
you can tell what would you expect at URV VSDPS?
Sir, extreme right axis
Examiners
deviation more
can
than
answer.
120 degree.
Huh?
Extreme right axis deviation more than 120 degrees.
Yes, a little more rightward axis, little more rightward. Tetralogy generally it is less than 150. Oh, here is classical 110. Very good. Then
This is counter clock.
I'm not sure. No, actually, I'll tell you one thing. You are with ESD, you can get left axis deviation. Counterclockwise, DRV with VSD, but not with PS. I mean, this is what I read in the books. Because I have seen 2 cases of DR with VSD pulmonary hypertension with extreme left axis deviation. But we are not probably not there for DRV with VSD with PS.
Yes.
I think the extreme axis deviation is the only clue. And of course, transition from V1 to V2, I'm not so sure. Probably typical for tetralogy, it may or it may not be there for DR. That's all. Yeah.
What about the left axis? What will you suspect with the background if there is a left axis?
Yeah.
Sir,
Yes,
left,
classical tetralogy FLO can have left axis. Very extremely
Yes.
rare, but they can have.
sir,
I
top with
can have
AR,
only if
can
it's
have
an
defects.
endocardial cushion defect. That's
Top
AV
a
can
with
have defects
tetralogy
with
variant.
present with tetralogy FLO.
the top with
AV can have
MAPCAS
defect with
AR.
tetralogy FLO. That can have left axis. Okay.
So,
There is one thing where extremely, as I said, double outlet right ventricle can have a left axis, but usually the pulmonary hypertension with left axis. Then tricuspid atresia, obviously there are no other features to suggest left axis. Single
left
ventricles
axis.
minority can have left axis deviation. Single ventricle with inverted ventricle can have left axis.
Yeah, yeah.
Then corrected transmission of late arteries, they also can have a left axis deviation. So the question is, the left axis in a tetralogy FLO like situation like what we are facing, we have to take 2 or 3 conditions. That is all. X-ray.
Yes, sir. Proceeding with the X-ray, sir. This chest X-ray PA view with adequate exposure and slight rotation to the right with the situs solitus levocardia with RV type of apex with concave main pulmonary artery with left-sided aortic arch with the prominent bronchovascular markings.
No, don't say prominent bronchovascular markings. We are
Adequate.
interested
Pulmonary
only in the
artery markings,
pulmonary
yeah, right?
vasculature.
Adequate.
Is
What
the
about tell us
pulmonary
about
blood
the
flow
pulmonary artery
normal or
to get the
less?
longest?
Sir.
What is
What
the
is the
pulmonary
odd
arteries?
finding in this thing?
I agree with you.
There
There
is
is a concavity at expected the pulmonary segment, but what about RPA, LPA?
Yes, sir.
Hair
That's
size.
Let's say odd thing. What is the odd thing in that?
Sir,
What is the striking odd point? Panelist. Panelist. What is the pulmonary blood flow? What do you think? And you support that. What is the pulmonary blood flow in this case? Is it normal, decrease, or increase?
Slightly increased.
No. Now that's a problem. Even though the right pulmonary artery is seen, if you look at the vessels, it are very thin, and you can see the end-on vessels. The end-on vessels, the diameter is very small. So you can see the end-on vessels on the right side. But the oddity is the left pulmonary artery seems to be more prominent than the right pulmonary artery. That is one thing which you have to keep in mind. Okay, LTGA we have excluded. Left aortic arch, you should be careful. Okay, we are seeing the aortic knuckle on the left side, but you should have a better X-ray because you'll be asked. That may not be the diagnostic thing. You have to have a better X-ray to look for the indentation on the lower part of the trachea. The pulmonary vasculature, you cannot say it
is to look for
normal.
the descending aorta.
Yes,
Descending
someone-
thoracic aorta on the right side, right arch. On the left side, left arch. So it's clearly on the left side. So it's only a left arch. I agree with you that the LPA is a little more prominent, but I don't think the vascularity is increased, but then that's all subjective. That's why I always ask for the ECG first, then the X-ray, because X-ray gives you a lot of opinions. And
I think
while
even if there
ECGs
are
don't,
vessels seen,
ECG's interpretation may be different, but the findings are
solid.
black and white. So
There's
X-ray
no
obviously
controversy
there
on
can
the
be.
findings.
Shall we
Here
go
I
to the
thought the
next?
pulmonary if the main pulmonary artery is not seen, the right pulmonary artery is seen. The LPA seems to be much larger compared to the RPA, which I thought was a little odd. Then if we, apart from that central vessels, the peripheral vessels are very thin, and the end-on vessels which are seeing are very, very small. So personally, I feel that the pulmonary vasculature is, pulmonary blood flow is on the lower side. I have to look for a dilated left pulmonary artery. So how will you explain that? Dilated pulmonary artery, not very difficult to explain, but there is one situation where you have to think for an obstruction distal to the infundibulum. You may have to look a little beyond to see why the left pulmonary artery is dilated. Okay, that's the only thing which I look for in this case. Otherwise, it looks like a fairly typical tetralogy FLO. The apex is classical, LTGA is out, DTGA is out, DRV you cannot exclude because it's almost same. But a typical boot-shaped heart is fairly described well in tetralogy. The left pulmonary artery, I have to look for the level of obstruction in the RV output tract. Okay.
Yeah.
Echocardiogram.
Yes, sir. Proceeding with the echocardiography, the pulse wave Doppler from the epigastric area showing aorta on the left side and IVC on the right side, suggestive of situs solitus with the
Okay,
apex.
you can put it as situs solitus.
Okay, sir.
Okay,
The
fine.
side with levocardia, with apex pointing towards the left, with the IVC draining into the morphological chamber right atrium, and the pulmonary vein draining into the morphological chamber on the left side, left atrium, with the apical 4 chamber and 5 chamber simultaneously showing there is a AV concordance with the morphological RV is on the right side with the valvular morphology and the ventricular morphology, and the apical 5 chamber on the right side showing LV opening into the aorta, which VA concordance also with the.
Now, what about the override?
Yes, sir.
It's not best to tell you about the override of the
Yes, sir.
VSD and
Yes, sir. With the aortic overriding of approximately less than 50%, sir. Which
less than 50%.
Yes, sir.
And you have to see
For
that
completion sake, you may have to
once more.
Yes, sir. In parasternal long. In further slides, sir. Yes, sir. This.
We have to talk about aortomitral continuity also for completion sake.
Yes, yes,
That,
yes.
with all the points to be discussed, we have to talk about the aortomitral continuity also. Then certain questions you can get away from that. Okay.
Yes, sir. And these are simultaneous apical 2D and color flow, showing there is no muscular VSD with the apical 4 chamber showing.
That will be difficult because in this situation,
ventricles
the
are
RV
identical,
and
you know, so
systolic
it may be
pressures
easy.
are the same.
But there are no AV valve regurgitations. No AV
Yes,
valve
sir. Yes, sir. Yes,
That
sir.
is important, isn't it? Ventricular functions are good. Both ventricles function good.
Yes.
Don't talk about muscular VSD. Don't say that there is no muscular VSD because they will ask you because the pressures are same. Then the flow is capillary. So we are less likely to pick up even if there is a muscular VSD. So don't say no.
The VSD and RV is also pumping into the aorta, isn't it?
Yes, sir. Yes.
Posterior vessel. Okay, go ahead.
Yes, sir.
So it's a biventricular, that is RV to aorta, right to left side.
Yes, so this
You have to
parasternal long
look for
axis.
AR. Yeah.
Yes, sir. Parasternal long axis view showing a large malaligned subaortic VSD with overriding of the aorta with aortomitral continuity maintained with the bidirectional shunt with LV and RV both opening into the aorta. And this parasternal short axis at the ventricular level showing normal ventricle with the slight.
The aorta is dilated. You have
yes,
to tell that the aorta was large. You have to take the measurement. Aorta is large. That means you are not expecting you are expecting a very relatively small pulmonary artery. Okay.
Common dilated aorta with a relatively less pulmonary
no
artery.
AR, you have to tell at that point.
No regurgitation.
Okay. No MR, no AR.
No MR, no valvular AV valve regurgitation or an AR with parasternal short axis at ventricular level showing
not ventricular level.
Slight D-shaped. Yes, sir. Yes, with that, with this second simultaneous 2D and color view at the focusing at the RVOT showing no significant RVOT obstruction. With this,
what did you say?
Sir, significant turbulence at the turbulence at
there is a turbulence. You mean significant? No, I thought I heard no significant. There is a turbulence in the subpulmonary region, isn't it?
Yes, sir.
You can see the pulmonary valve there.
Yes,
okay?
Sir.
Yeah.
Yes,
pulmonary valve is distal to it. Yeah.
Pulmonary valve is distal and flow acceleration is occurring below the pulmonary valve. But this is important because now you look at that. Where is the obstruction now?
Parasternal short axis at the valvular and focusing at the valvular level with suggestive of severe pulmonary stenosis.
That's an important thing. Now what we have to identify is the RV outflow, starting from the right ventricle, outflow tract, valve and beyond. That is important because this is extremely important. You will be asked questions on this thing. Okay.
With the left-sided aorta. With left-sided
now
aortic
you talk about the gradient. Where is it arising?
Tell us the gradient.
Gradient, yes, shape of the gradient, all those things. What is the level of obstruction?
Yes, sir.
That is important thing.
Yes, sir. Actually, sir, in our case, we have tracked down from the pulmonary valve to the RVOT, and we have got the gradient mainly at the valvular level with the pulse wave, and not at the significantly at the RVOT level, sir. In this patient.
Basically, the color
valvular or subvalvular?
Sir, valvular level, sir.
Okay, I mean, I'm not so sure because here the turbulence is also at the pulmonary valve. But obviously, you see, tetralogy, subvalvular pulmonary stenosis has to be there.
Yes, sir.
There is additional valvular, annular, and supravalvular is different. But because it's a malaligned VSD, there has to be subvalvular stenosis.
Yes, sir,
Now,
yes.
severity, this may be a good anatomic pathology where, subvalvular stenosis is not very severe. And that is the reason the patient has come to this age. And also the pulmonary vascularity was normal. So it is a fairly good anatomic pathology of failure.
Yes,
That's what I would say. But I'm still not sure that grading is only at subvalvular level. That I think is very difficult to tell. Anyway,
basically the pulmonary artery size is important. The pulmonary artery is of good size, whatever you are saying. The pulmonary
wave will
valve
only give you a single summation of all gradients. But if you use pulse wave,
okay.
you will probably be able to differentiate subvalvular against a valve. Okay, great.
I think what you can look into the spectral trace. Spectral trace, it favors that there may be an additional thing inside. And I personally feel it is more at the valvular level. Looking at the turbulence occurring just very close to the pulmonary valve and the trace, spectral trace, more of a valvular thing. And you will be asked about the hemodynamics of this. Because looking at this, what do you think? Now, is this data adequate or not? That's a thing which we'll ask. So the gradient, how much is the gradient? It is 96. Is that
Sir.
what you expected?
Sir,
You expected that? Yes.
So
Why?
How would you calculate the gradient expected at
Yeah.
echo by a clinical?
Yeah, sir, I didn't get it, sir. Sorry, sir.
No, but it pressures or pressures in all the chambers and great arteries.
How
That is
would you
what we
predict?
want.
How will
The
you
two
predict
great arteries and
how
the
will
two
you predict the
ventricles.
gradient across the outflow from clinical examination? That is blood pressure, systemic blood pressure, isn't
Yes,
it?
sir, yes, sir, yes, sir,
120
yes, sir.
minus
Yes,
blood
sir.
pressure is not more than 30 in all
Yes,
pathology physiology. So it has to be 120 minus 30, right?
Yes, sir. Yes, sir, yes, sir.
So we know the diatic pressure is 110,
100.
LV systolic pressure 110, RV systolic pressure is around 110, and a gradient of 96. That means the pulmonary artery pressure is likely to be 20 to 25. That is what
Yes,
we want. That's the thing which will be asked.
Yes,
Okay,
sir.
fine.
Okay.
Then do you have further data?
Can you see
Yes,
the
sir.
pulmonary arteries? Pulmonary artery size
Pulmonary
and all?
artery.
Not
Yes, sir,
visible,
yes,
I think.
sir. Sir, slides. We don't have slide, but I have seen the adequate RP and LP also seen. Sir,
To be measured,
confluent. Yes, sir, yes, sir.
What
Confluent
are those
pulmonary.
two? There are two indexes for pulmonary
Yes,
artery
sir, yes, sir,
adequacy for
yes, sir.
repair.
Yes, sir. Further, sir, I have taken on the CT after the
Okay.
echocardiography also, McBoon
right.
ratio and Nakata index, sir.
Okay.
There is certainly
No,
severe
for completion's sake, you should have the detailed anatomy because it is not difficult.
Yes, sir. Yeah, yes, sir.
Not
Yes, sir.
difficult in this case. So you should go to the suprasternal view also to
Yes, sir.
delineate this thing. Okay, because it is okay, fine. You have that suprasternal view.
Showing
no
left side.
coarctation, obviously.
Yeah.
But you have to look for that. Then the aortic root, look for coronary anomalies if possible. So you have to look into the coronary artery origin if possible. It may not be easy in a 28-year-old female, but you have to attempt say that, sir, I could see or I could not see the coronary
Yes,
arteries
sir.
very well. That means
Yes, sir.
you are looking for coronary anomaly also in these types of cases.
Yes,
Then
sir.
from this, you have to look into the pulmonary artery size. These are things which you have to do in an echocardiographic evaluation. So the great arteries, the chambers, the veins, the coronaries. Okay.
Yes, sir.
Fine.
So the final
I'd like
echocardiography
to
report.
Are you expecting collaterals in this case? Aortopulmonary collaterals in this case?
Sir, as there is already
Less
adequate
likely because the pulmonary blood flow is reasonable.
Yes,
There is a reasonable pulmonary blood flow with a good sized main pulmonary artery, all those things. We are not expecting major aortopulmonary collaterals. Okay.
yes, sir. So the situs solitus levocardia, AVVA concordance with normal related great arteries with normal biventricular function with large malaligned non-restricted subaortic VSD with aortic overriding of nearly 50% with maintained aortomitral continuity with severe valvular PS, pulmonary stenosis with confluent pulmonary artery with normal origin of coronary confluent pulmonary artery with normal origin of coronary arteries suggestive. So, sir. To further narrow down the differential, like aortomitral continuity was maintained. So the DORV feature against the DORV, and
We need not complicate the
okay, sir.
issue.
Okay, sir.
You can say the
please go
finding
ahead.
is fairly typical of a
Yes, sir.
classical tetralogy of Fowler.
So-
Only thing is, as Professor Jagan said, you should do pulse Doppler in the subvalvular, valvular, and at other levels. Okay,
So-
that's
yes,
important.
yes,
So this is otherwise a straightforward case. But what we need is the
I
levels
think
of
it
obstruction
is
by
still
pulse Doppler.
significant subvalvular plus valvular maybe little annular also, because annulus also is a bit small. And RPLP, of course, I think are adequate size, but you'll have to measure it by maybe CT. Okay, you can
Okay,
go to CT if you are.
yes, sir. So to further assessment of RVOT, coronary arteries, pulmonary arteries, and pulmonary valve anatomy, we further proceed with the cardiac CT and also the collateral, but we didn't expect in this case. So this is a RVOT thickening of 9.2 mm with causing mild to moderate subvalvular stenosis on CT with the Magoon ratio by RPA and LPA diameter with respect to the DT at the diaphragm of 2.86, that was adequate, and the Nakata index with the cross-sectional area of the right pulmonary artery and left pulmonary artery with respect to the body surface area, the 437, that is more than 330, is also adequate with the normal origin of coronaries with the
Let me see the coronaries. You have
yes,
the
sir.
picture?
Yes, sir. Yes, sir. Yes, sir. With
The
left coronary
coronaries.
artery. Yes, sir.
Okay.
Okay.
Yes, sir. With the
Okay.
minimal collaterals were there, like right bronchial artery and the non-bronchial systemic artery from the left subclavian arteries.
Pardon?
Sir, with minimal collaterals or
collaterals I have seen.
minimal, yes, sir.
Yeah. Very. From that aorta, there is a collateral going.
Yes, sir.
Okay,
Right
fine.
bronchial artery and the non-bronchial systemic artery from the left subclavian artery.
Left subclavian.
And I just want to tell you only one thing. You should not only say the origin of the coronary arteries left and right normal. Often what happens is an RV branch which crosses the RV outflow,
yes,
and which is large and runs parallel to the interventricular. That has to be sacrificed because it may not have the same weightage as LAD, but it increases the risk. So you have to think of, you should see that also. So there is a large coronal artery going down the interventricular septum parallel to the LAD.
Yes, sir.
Okay.
So
I think that's enough.
So the final.
So when you are presenting the data, the important things, as Professor Jagan said, the majority of the cardiac anatomy is very clear for us. So we don't want that. RVOT, as we have said, or that is, we have to look at the levels. We have shown that there is a subvalvular obstruction as well as a valvular obstruction. Then all the indices you have measured. Then the coronary arteries. You have done a CT angiogram. So we concentrate on the coronary artery so that you can avoid an invasive procedure. So the coronary artery anatomy delineation is the most important thing which you have to look for in the CT, because all the other things are not that relevant. For example, collaterals, we are not expecting much collaterals. Even if there are a few collaterals, we are not going to do anything for that.
Yes.
So the important thing is the RVOT anatomy and the coronaries. That is what we want. Probably the pulmonary venous drainage you have to look into. Because even though echocardiogram, we have seen 2 or 3 pulmonary veins, we have to look specifically for the vasculature in this case rather than the cardiac anatomy. That is the importance of CT angiogram. That is looking for the vascular anatomy, the aorta and its branches, the coronary arteries, the RVOT and the pulmonary arteries, and the pulmonary venous drainage. The systemic venous drainage obviously will be normal. We are not expecting that. So because we have seen that IVC is draining to the right atrium. So these are things which you have to concentrate. And then obviously the indices. Okay.
So
there is a question coming. That is LPA prominent. Does it mean a delayed closure of PDA? I think we need not go to that.
To be frank, I do not know. I don't know.
Sure.
But certainly,
we need not think in that line.
Yeah, if the valvular PS was the dominant lesion, then you can even have explanation for the LPA being a little more. For that is the reason that LPA, I mean, the pulmonary stenosis may be significant. That can allow LPA to be a little more larger than that. The other one, I'm not sure.
That is easier.
I'm not coming.
So the other thing is hypothesis also, it will be difficult to explain, because why the LPA should be prominent in a normal pulmonary artery anatomy when there is a PDA, because the flow will be equal to both sides. The flow still will be more to the right pulmonary artery, because the flow is determined by the pulmonary vasculature and the lung volume, because more blood has to flow to the right lung. So if there is a connection, blood flow will go to the right side. But the easiest way we have found, there is an obstruction at the infundibular level and valvular level. So if somebody asks, can you hear P2 in this case? It may be possible. That's only situation where you can hear. That's a question which is asked. A split second zone in a tetralogy of fellow, in a mild tetralogy of fellow with a good pulmonary blood flow, you can have. Second thing is, when there is an associated valvular pulmonary stenosis, you can have. Then second, when there is a peripheral pulmonary artery stenosis, the central pulmonary artery pressure can go a little higher, you can have. If there is extensive aorta pulmonary collaterals, you may hear a P2. Following a BT shunt, or when there is a very development of pulmonary vascular disease, when there is an extensive aorta pulmonary, because this is a postgraduate level discussion, that's why I'm discussing that. But somebody may ask you split second sound audible P2. What they want first is the associate valvular pulmonary stenosis.
I think
The rest
P2
of the things,
auditory pathology, I think should be in order of preference, good anatomy pulmonary pathology fellow with good pulmonary blood. Right?
Yeah.
Where the infundibulum pulmonary stenosis is optimal, good pulmonary blood flow, P2 can be audible. Rarely, as you correctly said, pulmonary valve stenosis may cause a pulmonary valve to be audible if pulmonary stenosis is the significant lesion. Otherwise, I think pathology, pulmonary component is very rarely seen. Very rarely.
For practical purpose, it is absent. It has to be single.
Rarely,
If you
rarely.
hear a single second sound, don't entertain tetralogy of Fallot. Straightforward. Okay.
That's right. Okay. I think
So-
it's anyway good.
It has been written.
It's good.
Coronary artery normal origin coefficient non-obstructive. Systemic collaterals minimum. Okay. It is straightforward now.
Yes, sir. So the final diagnosis of cytosolitis levocardia, cyanotic congenital heart disease, with etiology of fellow with confluent pulmonary arteries, with NYHA3 functional class, with normal sinus rhythm, with no evidence of congestive cardiac heart failure or endocarditis features.
Because we are running short of time.
Yeah. So I think we'll just summarize why this patient is an unusual case. Yes. In the Western countries, this would be an unusual case for a classical tetralogy to survive. They would, as Dr. Sujay said, it would have been very difficult anatomies, not correctable, only would have survived. In India, we still find large areas of population which have no access to higher pediatric cardiac centers, and hence some of these will continue to come to adulthood. So I think otherwise everything is fitting into a tetralogy, classical tetralogy, and obviously survival is better for tetralogies where the anatomy is the best, or in pulmonary atresia with aorta pulmonary collaterals, where ultimately they die of heart failure rather than anything else. Anything else, Sudhir, to come?
The only thing that will be discussed in the what we have to consider is we will be planning surgery, but what are the problems of surgery in a 27-year-old female when they are submitted for tetralogy of correction? Whatever we have is children operated, but as age advances, what are the problems that can occur post-operatively? Especially the pulmonary regurgitation, right ventricular dysfunction. Also, your evaluation of the right ventricular function in this case is important. So when you are taking up this patient, coronary anatomy is very important, pulmonary vasculature is very important. The right ventricular function has to be assessed by a cardiac MRI before submitting the patient for surgery to assess the outcome, the intraoperative, postoperative, long-term outcome that you read up. So that is very important in this case, because don't think that this is a straightforward case with an excellent result. The patient may land up with postoperative right ventricular dysfunction, very higher chance. So make sure that the right ventricular function is good now. If there is right ventricular dysfunction by cardiac MR, then the operative risk and post-operative outcome will not be that encouraging. That's all what I want to contribute. Am I right?
Yeah, perfect. That's correct. Certainly, adult tetralogy correction is certainly not the same ball game as in 2-year-old or 3-year-old. They'll have ventricular dysfunction. They will tolerate. They'll have right ventricular restrictive physiology. So even mild pulmonary regurgitation, which is almost always going to be there in any tetralogy outflow repair, will not be tolerated as well as in a child. They would go into right heart failure, and of course, adult onset arrhythmias because of an RV outflow scar. So some of the things, but otherwise overall anatomy is fair. Clinically, the RV function looks good, but certainly there may be some fibrosis due to chronic hypoxemia and systemic RV pressures. So these are things to be looked at to assess and analyze before giving a profile to the patient and consideration of surgery. Would you allow her to marry? I mean, last question, just before time up. I don't know.
Sir, the pregnancy basically is poorly tolerated in these patients because
no, don't tell that. Don't
marry.
tell that.
Will you marry? So, yeah, so they don't say marriage and pregnancy together. Marriage, but she can't have she cannot undergo pregnancy for why? Can you tell me the reason why?
Yes, because sir, basically the systemic vascular resistance, because systemic vasodilation in pregnancy causing
No. The fetal loss is almost
almost high.
100% when saturation is close to 80%. 85% itself, the fetal loss is 80%. But if the saturation is 89 to 90, above 90, the fetal loss is only 10 to 20%. Right? So it is fetal risk far more than the maternal risk. Maternal risk is there, but risk is for the fetus.
Proper
Fetus.
counseling. Marriage, we have to
Counsel.
discuss. Because they are very
Because at 82%, I don't think
counseling.
she can have a live baby. Marriage is no
Because we have
contradiction.
cases. So proper counseling about the consequence, because we have cases where they have survived without, because her long-term survival may not be that bad in this case. Because looking at the pulmonary anatomy and the flow pattern, the long-term survival may not be a major issue. So counseling before pregnancy, all those things have to be explained, because we have cases where relatively high risk cases have undergone marriage, and because of their desire, they had a successful pregnancies with reasonable outcome, but the high risk has to be explained. I think that's okay. Any doubts from your side? Any other points to be clarified? We didn't give chance to the panelists. It has been a Kuldeep show today. Any questions, points to be discussed, Jibma group? Okay, unmute. Fine. Is it okay, Professor Jagan?
Yeah, I think we have concluded. I think that's good case. Of course, as I said, there are still areas in India where pediatric cardiac surgery is still not available to the large section of the population. And obviously, congenital heart disease does not differentiate between socioeconomic. It is across the population. Thank you, Hari. And
thank you, sir. I think everybody should agree that this was a wonderful discussion and we learned a lot. So thank you, Tharayan sir, Sudhir sir, and the team. And Dr. Kuldeep Gaur presented very well. And it was discussed by the Jibma team also well. So thank you, everyone. So we will have the next presentation on August 9th. Again, we will have two other groups presenting, and we will have another topic also, which we have not decided yet. So we'll inform you. So we will keep you posted. So over to Arun for the vote of thanks.
Yeah,
Yes,
Dr. Kuldeep has done good homework, because he has presented very well. He answered many questions, and he did not give chance to the Jibma team to answer, because he was answering all. It was a wonderful performance from the whole team. And thank you very much, Harikrishnan et al., Arun, for giving us the chance to interact and learn.
Thank you, sir. As everyone agrees, it was a fabulous session. And it was started off wonderfully by Dr. Michelle Kettleson. If you're not aware, actually, she is the Director of Postgraduate Education, Heart Failure and Transplantation from Smith Heart Institute, Cedars Sinai. And she's heart failure, research professor in cardiology there. So it's a major person we've got today for the live presentation and discussion as well. That was fabulous. And then we had a wonderful case discussion led by Tharayan sir and Sudhir sir. Thank you, Dr. Mayank, for joining in as well, and well presented the presenter from AIMS Jodhpur, Dr. Kuldeep. Sad to say that the Jibma panel could not get the opportunity to contribute too many times, but nevertheless they were also actively involved. So thank you, everyone. Dr. Shiva Vignesh, Dr. Balaji, Dr. Shahid. Let's also thank the faculty from Jibma for providing, and from both institutes for permitting the postgraduates to participate. I should thank the Heart Failure Association of India, Dr. Chopra sir, Dr. Venu sir, Harishan sir, Dr. Sarjan, Dr. Abraham, and also the Heart Failure Society of America for collaborating with us. We have received support from Sun Farm. I think they've ensured that the clinics is transmitted live across the globe now, and it's taken well by Netcast and team. There are people, Sumita and others, who work behind to ensure that this goes on monthly in an efficient manner, and we are proud to say that this is now an international program of repute. We'll get back next month, as Sir said. Till then, see you. Good night, and let's continue learning.
Good night.
Thank you. Good night, sir. Good night.
Good night.
Right.